Good afternoon. My name is Bruce Small, and we'll be doing a presentation on righting the ship, correcting the overdose problems at Springfield General Hospital. The agenda goes as follows. Slide 1, title page. Slide 2, agenda. Slide 3, problems at Springfield General. Slide 4, and Slide 5, a national problem, not just a Springfield General problem. Slide 6, the change process. Slide 7, treatment failed. Slide 8, mutual agreement. Slide 9 will be the end of the presentation with any questions if needed. Problems at Springfield General. They wanted to use the technology to solve medical mistakes that have been plaguing the institution for years. Now, just like Nurse Jackie here on the picture, my nurses, you guys look at it with some extreme skepticism and having a machine do for you what you've been doing yourself for generations. But there are errors, prescribing errors, confusion over which drugs to use with similar names, inadequate attention to the synergistic effects of multiple drugs for a patient. National problem. It's not just a Springfield problem, ladies and gentlemen. As you know, as nurses go, you know that there is a prescription problem. And this problem is we refer to as an adverse drug event. These events kill or harm over 770,000 patients annually in the U.S. Doesn't kill them sometimes, but there is some significant harm and or death that happens to these patients. National problem. More than a Springfield problem. As you can see here, sometimes these prescriptions can be confusing, like Leonidas here. This is confusing. Handwriting. As you notice from those, when you get handwriting for you guys, it's probably 10th, 11th, 12th. And then when you get down to the junior doctor, senior doctor specialist, it looks like scratch. It doesn't look like anything. Healthcare costs due to adverse drug events rise by $700 billion a year. Nationally, handwriting identification is the most common type of error. The prescribing physician, uses poor or illegible handwriting. You guys can't read it. If you can't read it properly, sometimes there are errors involved in the prescription. Change process a better way. The solution, administrators at Springfield General decided they were going to take the prescription processing out of the hand of the doctors and out of the hand of the nurses. So they implemented this new system called the computerized physician orderly entry system. It was brought in to ensure safety and accuracy by the following steps. All prescriptions for medicine and treatment will be entered into the hospital's IT network. Computer entry is available to all hospital staff, treatment, and pharmacy staff. The system would catch all prescription errors, incorrect dosages, duplicate requisitions, patient allergies, and adverse impact statements of multiple medications being prescribed. The system would also display the patient's complete medical history, as well as guidelines for proper treatment. The results at Springfield General were surprisingly disappointing given the level of effort and resources spent to implement OPEC. We had incorrect dosage information. The dosage information listed in the CPAC display were based on the pharmacy's warehousing and not the clinical guidelines. Two different things. Discontinuation failures. It takes just as much to discontinue a medication as it does to input it into the system. That created a problem. Canceling was non-existent in some cases. Computer interface creates medication canceling ambiguities, which can result in prescriptions not being canceled properly. Then we have patient confusion. Incorrect patient files are selected due to similar names and drugs being close together. The different CPO computer screens offer different colors and typeface for the same information, which causes for the doctors and sometimes the nurses to misinterpret information. This all created a new problem. So the administrator decided that we're going to scrap CPA and go back to doing it manually. But we have to have some safeguards in place. First and foremost, safety is everybody's business. Springfield administration must anticipate errors but take the necessary realistic steps to correct those errors. Past events must be reviewed and analyzed with the goal toward learning, not punishment. So if you guys make a mistake, we're not here to pounce on you. We want you to do it right. But we also want you to understand that no one is looking to hang you if you make a mistake. We just want to learn from our mistakes. Management needs to be proactive by listening to doctors and particularly you nurses and other support staff to help minimize error traps and error producing factors. We all work together. We can all do this together. So, my nurses out there, do you have any questions for me or for this senior administration?